And this is another fantastic topic from our great friends and colleagues, and I need to say pioneers, certainly in this area also of disc arthroplasty, our friends at the Texas Back Institute. And it's a really cool topic because it kind of looks at things from a perspective of different cultures where different standards apply on the well-known, and thanks to our TBI colleagues, very well-established merits of spinal arthroplasty. And without much further ado, I'll punt over to our friends in Plano who are all assembled here. Alex, are you going to take the lead, or who's starting to speak?
I'm going to take the lead. Thank you so much, Dr. Chapman, and thank you to Seattle Science Foundation for inviting us again this year. I'd also like to thank our fellows who put together great talks despite it being their first week of fellowship and having a lot going on. So I'm just going to share my screen right now.
Recording in progress.
Perfect. And so today we'll be discussing the European cervical arthroplasty trials. I think a very natural reaction that I got from some people is, why are we discussing these European trials? We've obviously discussed the US FDA IDE trials at length, but why are we looking to these European trials? And so this is me a lot of the time on social media and LinkedIn. And I think that the rationale for picking these trials is, the results are often dichotomous with the results of the US trials. And I think that oftentimes they're misinterpreted and people either read just the title or the abstract, and they really warrant a more in-depth, read and discussion. And I think that it's valuable to discuss this not only in the context of arthroplasty, but good for our fellows to kind of understand how to critically evaluate the literature as a whole. And so before the fellows present the articles, I thought it would be useful to discuss briefly the results and methods of the US trials, because I think it'll enrich our discussion of the European arthroplasty literature and provide a greater context. And so as of today, 10 implants have undergone FDA IDE trials to completion, with 9 receiving approval. Currently, there are 6 commercially available implants, and 3 have been approved for 2-level use. And all of these studies were comparing arthroplasty to ACDF. And so before we talk about the results of the trials, I think that this slide in particular is important. And if you look, these are the 2-year trials, the initial trials of the 6 commercially available devices. You can see that they're all prospective, some of which were randomized, and then some of the more recent ones have been with historical ACDF controls. You can see that the number of sites ranges from 13 to 23 with hundreds of patients. And I think that these are important things to make note of when we look at the European trials. So this is not my wine cellar, unfortunately. But I think that the cervical disc replacement literature from the US has aged like fine wine. And so the 2-year results really showed non-inferiority, but the benefits of the preserved motion were not necessarily seen during this shorter window. And we're fortunate now to have mid and long-term follow-up of these devices. And you're starting to see a divergence in the results, particularly with adjacent level disease and reoperation rates favoring disc replacement. And so we'll quickly go over the long-term results, or the longest term results we have from these US trials. And so the 7-year results of the single level ProDisc C were published in 2015. Over 90% of the 209 patients were available, and both fusion and arthroplasty were effective in reducing neck and arm pain and improving and maintaining function. However, significantly less patients in the arthroplasty group underwent secondary surgical procedures at the index level and overall. In 2018, the 7-year results from the Secure C trial were published, comparing Secure C to ACDF at a single level. And the Secure C patients were found to be statistically superior in regards to overall success, patient satisfaction. There was also lower rates of subsequent index level surgeries and device-related adverse events in the arthroplasty patients. In 2017, Chris Radcliffe published the results of both the single and two-level MOBI-C IDE trials. We're going to just focus on the single level results. And then based on the measure of composite success, there was no difference. But the single level MOBI-C arthroplasty patients had significantly lower rates of adjacent level surgery than the fusion patients. And it is worth noting that the two-level arthroplasty patients were statistically superior. The 7-year results of the Prestige LP were published in 2016. The patients that were treated with arthroplasty had significant improvements in pain and disability with similar rates of safety. The rates of adjacent level surgery were not trended towards favoring arthroplasty, but were not significantly different. We do have multiple devices that have been recently approved. The 2-year results of the MOBI-C, this is differs than some of the other commercially available implants in that it's elastomeric and has 6 degrees of freedom. And these results were non-inferior, but there have been some concerns recently about osteolysis. And so what we can talk about that another time. The 2-year results of the Simplify were published, and Dr. Geyer was the primary author on that paper. And the Simplify patients, when compared to historical controls, had significantly greater overall success. But like I mentioned, longer follow-up is needed to truly assess these newer implants. And so the currently available IDE studies all compare arthroplasty to fusion. And so we haven't necessarily looked at arthroplasty versus arthroplasty, but this is a great chart that Donna and Dr. Geyer put together. And you can see that these are the NDI scores. And you can see that not only is arthroplasty consistently lower than fusion, but the results are pretty consistent and they're maintained over time. Aside from the clinical benefit, what we're really looking for with arthroplasty is maintained motion. And so you can see here that there is some loss of motion over time, but it's maintained. And I think that if you think about this, when a successful fusion limits motion to 0, it just magnifies these results and they become even more impressive. And so a question that can be asked is, does this motion matter? And this was a publication from last year that Dr. Ziegler was an author on, where they looked at the 7-year results of the ProDisc and the impact of motion on adjacent level degeneration. And so the answer to the question is yes. And you can see a sequential decrease in the rates of radiographic degeneration with increased motion. And there's more to this paper, but for the sake of time, we'll move on. And so, we wanted to ask, and this is something that we published earlier this year, is too much motion a good thing? And so we looked at the results of the MOBI-C IDE trial, and you can see from these charts that obviously the ACDF patients had the highest rates, but it seems like there's a sweet spot in these mid quartiles of motion where your rates of adjacent level degeneration progression are the lowest. And when you get to the highest quartile, it starts to mimic the lower range and is different than the mid ranges. And this is also pretty interesting. You can see that these mid-range patients at 7 years, 70% of them had no adjacent level radiographic progression, and that's very different than the mid or than the low and high rates. And so we'll obviously don't want to take up too much time and get to the articles, but the US IDE trials have provided us with abundant high quality evidence. I think it is pretty safe to say that single and multi-level arthroplasty based on the results of this trial are superior at mid and long-term follow-up. The results have been reproducible across multiple devices, studies, centers. And I think as time progresses, we're starting to get a better understanding of what ideal motion is. Thank you.
Alex, that was a great overview. This is also an opportune time to just point out, first of all, acknowledging the incredible sophistication and ongoing evolution of knowledge that you and your center have provided with those tremendous pioneers who are on the screen. But a quick teaser: on October 13 and 14, 23, we have our annual, I think it's the 5th annual motion preservation course. We are very lucky and fortunate to host it here with many of the phenomenal colleagues of TBI as chairs here at the SSF facilities. You can watch it online if you're out of state, October 13, 14, 23. So just a little teaser. And Ben, can you fan out the camera? By the way, we have the next generation all excited here. We have our mini medical school here. Ben, can you show us a robot camera view of our audience? Sorry, the robot camera's not coming. Well, we have our mini medical school students here, and assume they're behind me, and I'm not going to ask them to stand up. The camera is frozen, it seems. So carry on this. I'm curious to hear your European results, but October 13, 14, Friday and Saturday, and thank you, Dr. Lau, for your nice comments in the chat room.
All right, we'll get started here. Thank you very much. My name is Connor Dunn. I'm one of the TBI fellows. So start with the
Our sound is very choppy right now.
Yeah, the sound's not great.
Yeah, Roger, can you look into that, please?
Is that better?
A little bit. You have to speak louder or increase the volume.
Connor, maybe bring the mic closer.
Yep, the cord fell out of the microphone. How's that?
That's much better.
All right, so we'll get started with the long-term results of the neck trial. Implanting a disc prosthesis after cervical anterior discectomy cannot prevent adjacent segment disease. 5-year clinical follow-up of a double-blind randomized controlled trial. This was published in the Spine Journal in 2022 out of the Netherlands. It is a follow-up study from their previous 2-year results. A little background: motion preservation, preserving ACDA in patients with cervical radiculopathy was introduced to prevent symptomatic adjacent segment degeneration as compared to ACDF fusion procedure. Prior reports suggest that ACDF is not more effective than anterior cervical discectomy alone for the treatment of cervical radiculopathy. The purpose of the study was to evaluate whether patients with cervical radiculopathy due to a herniated disc benefited more from undergoing ACDA, ACDF, or ACD in terms of clinical outcomes measured by the NDI. It is important to note that the original study sought to have the primary outcome as ASD, and then they changed it. In terms of methods, it was prospective, randomized, double-blind, multi-center clinical trial spanning from October of 2010 to July of 2014. Inclusion criteria included 18 to 65-year-old individuals with single-level radiculopathy, uni or bilateral. Exclusion was any previous spine surgery, instability, absence of motion, less than 3 millimeters of intervertebral space, severe segmental kyphosis, myelopathic neoplasm, traumatic origins, metabolic or bone disease. In the end, 109 patients were included, 35 in the arthroplasty group, 36 in the CDF, and 38 in the CDF group. The active C device was used for the ACDA and 3 different peak cages for the ACDF certain preference. This is just the chart outlining how they got down to their included patients. They had an overall compliance rate of 82% at follow-up 5 years. It was initially powered to evaluate NDI at the 2-year mark when they chose NDI as the primary outcome measure, assuming that ACDA is superior with a minimum of 111 patients for 2-group analysis, or 166 for this study to evaluate that primary outcome. Secondary outcomes were VAS and various other patient outcome scores. Also, they addressed radiographic kyphosis, and in terms of surgical outcomes, ASD reoperation and index reoperation. It's just a table demonstrating the patient demographics, which were all pretty consistent. throughout the groups. In terms of the results, looking at the primary outcome of NDI at 5 years, available in 82% of patients, it increased to 24 in the ACD group as compared to a decline to 13, 15 in ACDF and ACDA group, respectively, which was a significant difference between fusion arthroplasty to the decompression group. However, there was no significant difference found between the ACDA and ACDF group. Of note, they did decide to define the minimal clinical difference. It's 20 points on a 100-point NDI scale. No difference was achieved by this metric. There was no difference in VAS, arm, neck, or SF. 36 ACDF had the greatest improvement in the light curve perceived recovery, with ACD demonstrating statistical inferiority. The number of patients with kyphotic spine was deemed too small to draw any meaningful conclusions from that data. Also, 6 patients were reoperated on for symptomatic ACDF, symptomatic ASD, which included 3 from the fusion cohort and from the ACDA cohort. Their annual ASD rate was consistent with the literature's. In conclusion, ACD provides less favorable clinical results long-term, which is presumably caused by a delay in fusion of these segments. The study claims an absence of clinical superiority of ACDA and that clinically relevant ASD cannot be prevented. This is despite the fact that it was not powered to draw these conclusions. The strength of the study is designed with several limitations, including inadequate power, the definition of MCID difference at 20, which I couldn't really find a good literature source for that number. And then the original intention was to evaluate incidence of symptomatic ASD with NDI as a secondary outcome measure. That's all for that study.
Thanks, Connor. You know, I think that we actually just wrote up a letter to the editor in response to this. You know, I think completing a randomized trial, as a lot of people on this talk can attest to, is not easy. But there's a lot of issues with this study. You know, ultimately, they compared a very low number of arthroplasty to fusion patients. The initial study was really designed to look at adjacent segment disease. You know, I think one of the things that kind of rubbed me the wrong way a little bit is that they kind of make this grand assertion in their title. But if you really look at the methods of the study, it was really never intended to look at adjacent segment degeneration. And then, you know, for them to determine arthroplasty as being worth the cost, I guess, they wanted to see a 20-point difference between arthroplasty and fusion, which would have necessitated a negative NDI, which is also not possible. And so, you know, I think that the claims that are made are not necessarily backed up by the data, which is probably the theme of today.
If I may add to that, statistically speaking, so thank you for this article. This is for our young audience here, our young future medical students, an important thing, but also for our new fellows. This is a classic example of what I call a small group analysis fallacy. So the fallacy of a small group analysis is that if you have certain variables, you need to do a so-called power analysis. And just looking at this quickly, this should be about 1,000 patients, not 100. If you have 3 in each side, this is a small group analysis. It takes extra care to look at this very carefully to make sure, and literally every case, and if I, speaking as an editor-in-chief, I would want every one of those cases to be listed and identified as to what were some of the classic variables. So this is statistically suspect. The other thing, and we'll harp on that later, I'm sure, is I always love the cultural aspect of medicine. We overlook that, but the Dutch, I love them. We love them, except when we play soccer against them. But the main thing there is the Dutch have a long history of having negative studies. It's something in the culture, whether it's MIS surgery or here or there, it's a great reality check. But this is, again, in the culture of their medical establishment. They love basically just throwing shade on stuff. So I will acknowledge this paper. I will quote it, but every point, and especially the one on NDA, and again, not understanding that this is not a linear code, but a so-called bell curve code. So you can't weight this one point as one, which is what many medical administrators and third-party payers mistake it for. So thanks for this paper.
Yeah, I think that this certainly adds fuel to some of the fire. And then these studies are included in meta-analyses, and their legacy lives on forever. Can anybody speak on the practice, and it's kind of glossed over on our focus, but of just performing an anterior cervical discectomy and decompression without even a fusion?
Alex, this is interesting. It's sort of like an old school procedure. And years ago, a lot of the neurosurgeons touted that, I just do a discectomy, the patient either go on to fuse by themselves. I don't think anybody in the US, at least I'm not aware of, does this. I know there've been some MIS techniques where people have tried to take, little tiny tubes and go down along the uncus and go into the canal. But it's certainly not commonplace today. And it's kind of interesting that they use that as one of the comparators.
Well, and the other point to bring up is, and I didn't see any of the x-rays of their fusions. Typically, European fusions with cages are not integrated screw plate cages, really sometimes not even using a biologic in a cage. So essentially, the non-union rates are very high amongst just throwing a cage in a fusion. So they're kind of like two arthroplasty groups and an operation that no one else does. So that's the study.
Yeah, and I think the other thing that this points out, at least for the fellows and even the young docs up at Seattle Science, is that you have to not just read the abstract, you have to read the paper carefully. When you realize that they had 36 patients with an arthroplasty, and it was only one arthroplasty. In the US, we have our choices of 9 different arthroplasties, and we have hundreds, if not thousands, of patients that have now gone through this procedure, and they did a study on 36.
Yeah, and furthermore, the arthroplasty that they use is not even FDA approved here in the United States. And so, our ability to extrapolate to our patient populations and our devices is even further limited, which I think is an additional limitation of this study if we're thinking about how it affects our decision making here.
It's interesting enough. It's not a bad arthroplasty. I may be the only one on this call that's actually used the active C, but it was obviously outside the US. It's not a bad arthroplasty, but they just never wanted to fund a study to get it approved in the US.
Okay, Alex.
All right, my name's Matthew Prevel. I'm also one of the TBI fellows. I'm going over the article, Effect of Arthroplasty versus Fusion for Patients with Cervical Radiculopathy, randomized clinical trial. So just go through this quickly since Connor hit a lot of this, but 100,000 patients received treatment for radiculopathy annually in the U.S., anticipated to continue to increase over the years. Anterior cervical discectomy and fusion is the gold standard. And of course, there's increasing concern in literature regarding adjacent segment disease with fusion, as well as the discussion of arthroplasty maintaining that motion. And so this is kind of going over to NORCAT 5-year data. So the purpose of the paper was to investigate 5-year outcome in cervical arthroplasty versus fusion for operative treatment of single level radiculopathy at C6 or C7. It was a single blinded, multi-center randomized clinical trial performed in Norway, powered. They did power the trial to determine the MCID, which was listed as 10 points for the NDI. They had 136 patients randomized to either arthroplasty or fusion, 68 patients in each. The patients were blinded. They had to be blinded for at least 2 years and could elect to remain blinded further. The surgeon was blinded until after the decompression and end plate prep. However, obviously the surgeon putting in the implant would know. Those 2 prostheses were used below the Discover prosthesis as well as the Servios cage. So the results, if you look, all of the patient-reported outcomes, including NDI, EQ5D, as well as NRS arm pain and neck pain, all showed significant improvements from their baseline that you can picture here. There was also no statistical significance between arthroplasty versus the fusion group. which I kind of stated here earlier, the difference for arthroplasty pre-op and at 5-year post-op was 45.9. That improved to 22.2, and the fusion had similar results of preoperative NDI being 51.3, which improved to 21.3. Again, those were statistically significant, but no difference between arthroplasty versus fusion. So they had several secondary outcome measures, including the arm pain, neck pain, patients reoperated, as well as adjacent segment disease. Again, like I talked about, all were significantly improved patient-reported outcomes at the 5-year follow-up, but no difference between the two groups. So reoperations they looked at, arthroplasty had 11 reoperations in 10 patients. 4 were due to migration of the implant, 7 for continued radiculopathy. These were all found at the index level. Fusion had 8 reoperations, 7 were for continued radiculopathy, and they state 1 for adjacent segment disease, which is what they use for the statistical analysis. I'll go into that a little bit more in a second. And so this is just all of the reoperations that for the arthroplasty group, which you can see quickly over on the right side, that goes all at index level. And then these are the complications that they had for the fusion group. And they listed only 1 at the adjacent level. But if you look over there, there was multiple, there's at least 2 adjacent segment levels. The number 1, I believe this one was not included because they stated that it already had that prior, but did have adjacent level disease that worsened enough to need a reoperation. And then there was 3 additional levels that showed adjacent segment disease, 2 segments above the index procedure listed over there. So again, there were large improvements in all of the patient-reported measures, and these were sustained at 5 years for both groups, suggesting either fusion or arthroplasty are good options for radiculopathy. Article found no difference in adjacent segment disease, which again is reading fast as it's been hinted, discussing the last article, suggested no difference between adjacent segment disease and arthroplasty versus fusion. And again, prior to all the meta-analysis that we discussed at the start of this talk. You may consider the fusion group having 5 patients with adjacent segment disease if you look into the results on that table that I showed you versus just the one that they listed in their statistical analysis. So I do think there's some strengths to the paper. The patients were blinded and randomized. Limitations, they talk about due to the randomization of the nature that some of the patients that were signed up for arthroplasty may not have been included in the study, which would favor fusion. There was no well-defined reoperation criteria, leading to potential selection bias. And again, power of study was designed to detect the MCID for NDI, not to detect difference in adjacent segment disease. So with this, I think you can see that arthroplasty and fusion are both effective at treating cervical radiculopathy. However, I don't think I would infer the data regarding the adjacent segment disease for arthroplasty versus fusion. And that's all I've got on that paper.
So thank you for that.
Where to begin with this one?
You go first. Texas.
So, perhaps either Dr. Guy or Dr. Blumenthal can speak a little bit more about their experience with the Discover disc. As far as I'm aware, it's the lone FDA trial that was stopped prematurely and not completed because of the issues that were taking place.
That's correct. Dr. Blumenthal is the one that has experience. Scott?
So partially true. The Discover disc trial was stopped midway through the trial because of a 10% failure/revision rate. The part that's not true is there was another disc that was stopped in the middle of the trial, which was a disc that I designed for Blackstone, which had again about 10% failure rate. So we stopped that trial in the mid portion. So yeah, the Discover had some issues in the US.
Well, and it never completed the FDA trial. So again, when you read these papers and they're comparing something that never passed an FDA trial, which at at least at the time that we were testing the disc, was much more stringent than any trial in Europe. And you have to take it with a grain of salt. So yes, if you're considering ACDF against something that is inferior, that never has been used commercially, the results are pretty much as expected, although they actually weren't bad considering it was a bad disc.
Yeah, and again, I saw one of the cases on this fusion failure was a cage and a plate, but a lot of times they, again, in Europe, they just throw a cage in there and it kind of is just an arthroplasty.
The other thing that I think is also relevant to discuss, and, in one respect, you could say that it was a strength that they were blinded until implant placement. And, but a lot of people, the way they approach their decompression for fusion and arthroplasty is very different, particularly with end plate preparation. And so I think that's also something important to note. And I would imagine that they did not, but it's something that I think could really play in a role. That high number of index reoperations would make me very concerned.
Yeah, that's not consistent with the literature, or at least, the few studies that are out there on cervical revisions. It's just not that high. And then I think also 2023, in terms of preoperative planning, it's not a good study to just not say, prepare the disc and then we'll tell you what we're putting in, because as you know, we painstakingly measure on our packs sizes, and not all the discs come in the appropriate sizes, particularly for smaller patients. And some of these discs may have been oversized and not technically the right disc to put in there in the first place.
Yeah,
and I think Alex,
that's a great point.
Yeah. And I think also this paper points out how the evolution of arthroplasty has come, because as you said, Alex, a lot of these revisions were for cervical radiculopathy. And we stress that with the cervical disc replacement, it's a totally different operation than when you do a fusion. Whereas we have to decompress the neuroforamen bilaterally with an arthroplasty, whereas with the fusion, you can take a little bit of liberty, say, okay, with distraction and with the fusion, we don't have to do as much and be as careful. So again, this paper was done, before I think we learned a lot of the techniques, other than the fact that it was a terrible implant.
So let me harp on the
culture. And I think.
Sorry, you go first. You go first.
No, please go ahead.
So let me harp on.
I was just going to say, Dr. Sorry, go ahead. I'll mute.
My lips are sealed. No. Okay, a cultural theme again. So I actually want to take a different vantage point. I thought this is a encouraging study because I already pointed out the Dutch love to harp negatively on surgical techniques. And this is, I think, a Swedish study, if I remember that correctly. And they share that same theme. They love to basically look negatively on the latest and fanciest things. So this is cultural again. Considering that, this is actually a relatively positive paper for what comes out of Sweden, which, lest we forget, was the country of Alf Nachemsen, and I'm sure this sends shivers down the spines of Richard, Alex, and Scott, especially, and Jack, because these are, this was the guy who called spinal arthroplasty, quote, the rape of the spine in the 80s and 90s. So coming from Sweden, where they have a long culture to publish negative things, just like Holland, this is actually, relatively speaking, not that bad. I completely agree with all the other factors. And I hate to say it, but again, the standard of these studies is not remotely close to what you all have, for instance, contributed. Thank you. And sorry to interrupt.
No, it's fine. The other thing that this was, Matt, correct me if I'm wrong, but this was published in JAMA Surgery. So the journal, the main medical journal from the United States, published this study, and it just seems odd given the US experience with this discover arthroplasty. And so there definitely seems like, in general, we think of publication bias with positive results. It just seems somewhat odd to me that this trial was published in this journal. Any thoughts on that, Dr. Blumenthal?
No, all right. Got nothing on that.
I can assure you, if you submit a trial that has a positive surgical thing into that journal, it's not going to get accepted. We've tried several times, and despite having what I thought very good methodology and everything, there's a clear publication bias, and that's a fact. There's several journals, I'm not going to list them up, but we all know them, that clearly kind of, let's just put it this way, have a conservative outlook on surgical interventions.
I didn't see what journal that was in.
JAMA Surgery.
Oh, okay.
Why don't we get started with the next paper?
Hey, good morning, everyone. My name is Greg Feldberg. I'm another one of the TBI Spine Fellows. My article was out of JNS Spine, published in 2022. And it's the artificial disc replacement and adjacent segment pathology, 10-year outcomes of a randomized trial. This is also taken out of Sweden. Kind of like we've harped on already, ACDF is the surgical gold standard for treatment of cervical radiculopathy. Concern is that ACDF causes loss of motion in that fused segment, however, which can lead to accelerated ASD or adjacent segment disease. And the thought is that an artificial disc replacement can prevent ASD by preserving that segmental motion. The objective of this study was to compare how well disc replacement compares to fusion for protection against the adjacent segment disease. So this is a 10-year follow-up. It's another double-blinded, randomized prospective study. The patients were randomly assigned to undergo ACDF versus ADR at 3 different hospitals in Sweden between 2007 to 2011. The inclusion criteria included radicular symptoms for greater than 3 months, correlated MRI findings to their symptoms, involvement of 1 or 2 levels, eligibility for both treatments, and they had to be Swedish literate. Exclusion criteria were previous C-spine surgery, involvement of greater than 2 levels, severe facet arthropathy, symptoms of radiographic findings of myelopathy, history of drug abuse, dementia or poor compliance, malformation or instability, history of prior trauma, pregnancy, RA, malignancy, active infection, or other systemic illness, or allergy to NSAIDs. Kind of similar to the prior study, surgeons were blinded up until the point of implant placement. All the patients underwent the standard approach to the cervical spine, and they went nerve decompression, removal of PLL, and they would prepare the uncovertebral joint needed. At that point, they would decide whether or not they were putting in ACDF or disc replacement based off of what was handed to them. The fusion was done with tricortical iliac rest with plate fixation, and also similar to the last study, disc replacement was with the Discover disc. Primary outcome was the NDI score with the MCID of 15 to 17%, and they had prior studies and they reevaluated patients at 1, 2, 5, and 10 follow-up. They defined ASD with FlexX and MRI images, and they compared the MRI with the Miyazaki classification, which we'll talk about in a little bit. They defined motion at a segment as greater than or equal to 5-degree difference between the FlexX of 1 functional spinal unit. And clinical ASD and radiographic ASD, they differentiate between with clinical symptoms correlating with the radiographic ASD, or if it was just radiographic with no clinical symptoms. There were 153 participants, all between the ages of 25 to 60 years old, that were randomly assigned to disc replacement or ACDF. They did break down what levels were done globally. They didn't specify whether these levels were done for the ACDF or the ADR group, but what they found was the majority were done at 5-6, 6-7, and 5-7. And they found that both groups showed improvement in the primary NDI score. These are the baseline characteristics on the right that are in this table that show between the patient groups. They found the range of motion in the disc replacement group changed. It improved from 43 to 50 degrees. The ACDF group changed, so it decreased from 45 to 36. So there was an obviously significant difference between the ACDF and disc replacement group at 10 years. What they found was 19 patients in the ADR and 9 in the ACDF group underwent a secondary surgery. Most common cause for that was loosening and subsidence. Some other causes, 8 for the disc replacement, 7 in the ACDF for clinical ASD. Radiographic ASD changes between the two were not significant. This is a flow chart kind of showing the different patient groups. You're looking at the allocation. There was 83 in the yard group, 70 in the fusion group. And then if you jump down to the 10-year follow-up, they lost about 18 in the ADR and 16 in the ACPF. And they discontinued 15 in the ADR group for basically the causes that I already mentioned. This is the breakdown between the two groups for the Miyazaki classification, which is a radiographic way to classify disc degeneration. And what they're doing here is they're comparing the pre-op MRI to the 10-year MRI difference at the level above and the level below. And what this is showing at the bottom section is saying that the change in MRI was not significantly different between the two groups. Their final conclusions that they drew from the study were that the patient-reported outcomes between ACDF and ADR were were not significant different at 10 years. There was more reoperations in the ADR group compared to ACDF. That was most commonly due to subsidence or instability. And the preserved motion that they noted in the ADR group did not prevent radiographic progression of thickness. For my thoughts, this is a long follow-up study. It's about 10 years. There could be some possible participation bias as 10 years out, more pleased patients are going to be less likely to make those MRI and imaging appointments. And those with the chronic pain and were more displeased with the surgery are going to be more likely to participate. As we mentioned before, with the Discover implant, it has the highest rate of reoperation, which they actually also mentioned in the study. There was no bone density screening for the study, so that also correlates to the level of subsidence that could have occurred. The Miyazaki classification is, again, a change in MRI between the discs, and that's pretty subjective if you're looking at it. And there's no mention of which levels or how many levels were done for ACDF versus ADR. And the thought there could be that you're going to have a change in the level of ASD based off of where you are in the cervical spine. Everything happens.
Thanks, Greg. Any comments about this study? I think it's a bit of more of the same, and I think you pointed out some of the issues that are commonplace with these studies.
The problem I have with these studies is that they use the general term ADR. In reality, it should be that the results of this study showed that the Discover ADR had such and such results, because what they do, the person that is a non-discriminating reader of the article thinks that, okay, disc replacement really has no benefit over doing a fusion. But they don't allow the discrimination, although they mention that, yes, it's a discovered disc, but they don't clarify that the discovered disc, yes, it's good 10-year follow-up, that's great, but it's a disc that never passed, for example, the FDA trials. It hasn't been used after, I guess J&J has already taken it off the market. So it's like talking about an Etzel car that's been taken off the market. Oh, it was a great car for 10 years. Well, that car died and no one collects them, but anyway.
No, I have to agree with that. So, for example, the study that we did at TBI was like a half a dozen different discs, and there was a difference in revision between the discs, but generally, if you lump them all together, it was about 1 to 2%. And you could say that they're weighted to different discs or the other. We certainly did more of one than the other, but still, we've got enough. And the study was substantiated by other studies like Matt Scott Young's, where he put all his discs together, and I think his revision rate was like 2%. I mean, it was very consistent.
Jens, what do you think?
So I'll stay with my culture theme. So coming from that part of the world, I've always been amazed at the indications for surgery in other countries. I'm again using that term shade. I'm throwing shade on my countries, like in Germany, where I'm from. I was amazed in the early days of disc arthroplasty who got these. They literally, if you had a little bit of a dark gray disc somewhere, you got an extra disc, and they threw in discs at any level that had halfway signal anomalies and wasn't bright white. And the other thing is that in other countries, there are very loose indications. That same theme applies, and there's kind of a very kind of a distanced relationship to patients. This kind of patient ownership that has really emerged in the US does not exist in other healthcare systems. The surgeon's truly a technician who throws something in, and then after a short while, when there's no complication, the patient is done. Having like what you guys do, or what we saw with Rick Sasso or Mike Jansen in our disc arthroplasty quarterly last month, is unprecedented. That there are patients coming back 20 years later because they have no problems, but they are happy to be followed up. That's literally unheard of in Europe. That's just not there. That's not in the culture of that system. So this is something to, again, point out. And we have to not ignore that these studies are used also for political purposes. So putting the last study and this one together, in our own state, our own kind of a statewide approvals board for procedures through government insurances used a Norwegian study where surgeons put in 2 to 3 level lumbar disc replacements without a vascular surgeon. There were 1 or 2 bad complications with the access. This was used as a evidence that this was a dangerous procedure. This would never happen here. We have access surgeons. We would never do 3 or 4 levels. But again, in Europe, this is a different standard. And these surgeons never have the same subspecialization that, for instance, you guys have in Plano, where there are artists who do amazing things. So we have to always remember where something's from and what their culture is and how their indications are reviewed. We're sitting in our indications conference here, and we'll have a vigorous debate about indications, especially with our next generation medical students sitting right behind me here. So this is again the important impact to not forget. And procedures are not the same, devices are not the same, culture is not the same, but also surgeons are not the same. And I hate to say that. There are few artists of your elevation who do disc replacements as beautifully as you do.
Alex?
Let's bring it home with the last paper.
All right, good morning, everybody. Caitlin Fisher here, one of the Texas Back Institute Fellows, presenting our last paper of the morning. So my paper was, what's the best surgical treatment for patients with cervical radiculopathy due to single level degenerative disease? This is a randomized controlled trial. This is done out of the Netherlands, published in 2017. So as we all are well aware, cervical disc degeneration with radiculopathy is a very common pathology. The majority of patients do improve with conservative management, but for those patients who fail conservative measures, we do have a variety of surgical options to treat them. The anterior approach being employed most commonly. So the objective of this paper was to assess the efficacy and compare patient-reported outcomes between 3 different surgical methods used to treat patients with single-level cervical radiculopathy. The first method was anterior cervical discectomy without implant. Second was an ACDF, and the third was a disc arthroplasty. As far as the methods for this paper, so this is a prospective, double-blind, randomized controlled trial. The surgeons were blinded until the night before, at which time they were informed of the surgery performing the next morning. It involved 142 patients with single-level cervical radiculopathy. Those patients were allocated 1-to-1-to-1 in the discectomy without implant, ACDF, and arthroplasty group. The exclusion criteria was pretty straightforward. Any prior surgical surgery that had been done, multi-level disease, any fixed kyphosis, and then age greater than 55. On the right there, this is just the baseline table for the patients who were included in the study. NDI was similar between the 3 groups with an average of 18.7, and total patients in each group was similar between 45 and 50. So as far as the surgical techniques, the anterior cervical discectomy was described as being done through a standard anterior approach that they would have used for an ACDF. And then once the complete discectomy was performed, they proceeded with wound closure without any implants. The ACDF group, it was done with a standalone cage by DePuy, as well as bone autograft. Of note, there was no plate used in those patients. And then in the disc arthroplasty group, they used the Bryan disc prosthesis from Medtronic. Patients were followed for a total of 60 months, and then they sent the questionnaires to the patients at 9 years postoperatively. Primary outcome measures they were looking at in this study were the NDI at 5 years, and then the secondary outcomes they were evaluating were multiple, but they were looking at the MPQ, the NRS, neck, arm pain scores, SF36, as well as complication calculus. The statistical analysis section of this paper is where things get a little bit rocky. So they did change from a non-inferiority study to a superiority study after the enrollment. Their sample size, they initially calculated that they would need 243 patients to achieve their power analysis and detect a difference of 10% between groups, which they fell short of by about 100 patients. And then they did note that they stopped enrolling the patients early, partly due to funding reasons, and then also due to other implants becoming available on the market during the course of the study. Also, their intent to treat analysis was based on the NDI. They noted that after they began the study, they were unfortunately unable to use the patient-reported outcomes they had originally intended to use because they never defined what an excellent outcome was before the study started. The results of this paper, so 45 patients underwent discectomy without implant, 47 had ACDF, and 50 had a disc arthroplasty. There was one intraoperative conversion for a patient who was supposed to receive disc arthroplasty who ended up receiving an ACDF. As mentioned, the baseline NDI was similar between all groups at 18.7 and improved by an average of 13.4 points at 2 years between all groups. It was 7.5 at the latest follow-up, and they detected no statistically significant difference between the groups. So as far as good outcomes, they define that as an NDI less than 7. They achieved that in 73% of the disc arthroplasty patients. A 60% good outcome was achieved in the ACDF group, and then 57% of the discectomy without implant patients. They concluded that there was no significant difference between those three groups, although, as you can see, there was a trend. As far as secondary outcomes go, the SF36, MPQ, and NRS all improved for each of the three groups, and they did not detect any statistically significant difference between those groups. There was a total of 11 patients who underwent reoperation. They had 3 patients who underwent surgery for recurrent radiculopathy at the same level, and then 8 patients underwent surgery for radiculopathy at an adjacent level. Complications in this study, so there was a total of 13 patients they noted to have complications with no difference they noted between the groups. Again, you can see a trend towards a difference between those three groups, although there was none detected. The vast majority of complications in this study was for hoarseness and dysphagia postoperatively. So the author's conclusion of this study was that anterior cervical discectomy without implants seems to be similar to ACDF with a standalone cage or with a disc prosthesis, although they do note that this statement should be considered inconclusive due to their small study sample size. And I don't think that the review of this paper is complete without at least shedding light on some of the limitations. So, and the authors did touch on this in their conclusion as well, but again, the sample size of this paper, they never reached their predetermined sample size of the study to achieve their power analysis and detect the difference. So for the medical students at SSF, you know, this is kind of your classic type 2 or beta error where you don't detect the difference if there is one. This is a single center study, although they initially were enrolled as a multi-center study, and they had several centers drop out with the development of newer implants, as well as lack of funding. The maximum age was also expanded to increase enrollment, so they did expand from age 50 to 55 after the study began. And then the implants used, so they were using the Bryan cervical disc prosthesis, which may not be as translatable to some of the newer generation prostheses that we're using now. Also, the ACDF was being done with a standalone cage without a plate. And then also, I think it would have been interesting to look at the radiographic outcomes of these patients, you know, especially looking at that discectomy without implant group, evaluating for kyphosis. And you know, I think that would have been an interesting point to touch on as well. So with that, I'll open it up to discussion.
Nice job. You know, I think that certainly shouldn't be a referendum on, you know, any broad region in regards to research as a whole. But I hope that when people read these studies, if they're able to watch this, they'll take, you know, a little bit more of a discerning eye to them and interpret them. And as was alluded to earlier, you know, a negative result of a study doesn't necessarily speak to the procedure as a whole, but more so with some of the individual discs, as well as some of the other issues with the methods.
Yeah, Alex, it's very interesting to see these European studies, and they always complain about the FDA trials because they've been funded by industry. But if you look at the strict criteria, the inclusion, the exclusion criteria, and how they're monitored, they really are beautiful studies. In the beginning, I used to be very envious of Europe and that they could bring products out very quickly. But now that we have monitoring up to 10 years, we're seeing the good, bad, and the ugly. Fortunately, mostly it's good with the arthroplasty, both in the cervical and lumbar. So I am much more appreciative of our you know, FDA trials than of anything else that we see anywhere else in the world.
Totally.
So many great observations here, all great presentations, thoughtful things. I do want to point out that, again, this is an emerging thing, but in the big picture, we can summarize a couple of things. Anti-cervical decompressions and reconstruction surgeries help patients, both in terms of neck pain and arm function. There are very clear safety standards that have now been applied for cervical disc arthroplasties. The catastrophes that everybody was fearing 20 years ago have not happened in the hands of diligent, good surgeons. There are clear preferences of people. And for me, looking back, this is a game changer. And I want to, again, thank you guys for having pioneered this and brought this to our shores and having applied highest scientific standards that others simply have not met in terms of looking at this critically. So this is above board. So this has been a significant breakthrough. And again, I myself, if I need it, I'll have a disc arthroplasty, not even a question anymore, knowing what I know. So these are, I think, some general summaries. The impact, and I think for our younger colleagues also, Ben, do you mind going over the room for a second? I think the camera's unfrozen now. This is the next generation. So I hope that understanding science and having a very solid foundation, not just because you have to publish something in terms of methodology, is really important as we have macro data available now, but always remembering cultural and individual preferences and idiosyncrasies as we're doing statistical analyses. And I think that's the time, somebody's timer went off, so the hour is over. Those are my bigger picture things, that this next generation is so cool that they're volunteering their time here and doing mini medical school and seeing excellent academic presentations by our colleagues in Texas, followed by colleagues around the world. Don't forget the October 13, Corey, do you mind flashing up October 13, 14 arthroplasty trial? You can see these wonderful colleagues live here performing demonstration surgeries. This is not advertisement, this is critical. critical peer review and discussions of the many unanswered questions and emerging technologies. So from here, I thank you all for this great, inspiring thing. And again, join us in the future. And thank you, Texas.
Thank you.
Thanks,
All right.
Jens.
Thanks, Jens, and thanks Seattle Science and Corey and everybody else. Alex, you did a great job, and so did our fellows. Thank you very, very much. This is great. Don't forget 1042 to get your credit. 1042.
Have a great
Have a
weekend,
good weekend.
everybody.
Thank you. Well, thanks for coming. Sorry. Surgeon's hours. They're not quite like banker's hours. Hey, Cliff, good to see you.